Good morning, everyone, and welcome to the Ask the Expert session on vaccine hesitancy. Today is Friday, the 19th of June, 2026, and it's just gone 8:30 in the morning in the UK. And I'd like to say a special welcome to Chris and Julie, our guests from Australia, and who are just about to go comfortably into their weekend, I'm sure, and to Neil Smith, who's in the UK as well. By way of a brief introduction, I will ask Chris and Julie and Neil just to give a brief introduction to themselves before they talk about their subject areas. So if I could pass over to you, Chris, to start off with.
Thanks very much, Guy, and welcome everyone. Some of you know me as a fellow of the Institute, but you might be interested to know how I fell into health emergencies. It dates back to the mid-80s when I worked for the Queensland Police on AIDS, HIV, and I remembered subsequent to our preparatory meeting that I actually ran a hepatitis B vaccination program for the police in Queensland, which was an interesting experience, something they'd never done before. But it became necessary because we had occupational
I
transmission of hepatitis B at the time. Quite a bit of, and I seem to have unstable internet. Probably Netflix as everybody's come home. It's evening here. So back to COVID, I worked with Indonesia, India, and the Middle East on COVID vaccination distribution, and then worked for the World Bank and HEPA, Health Emergency Preparedness and Response, which had two parts: finishing off the COVID vaccinations and preparing for the next pandemics. And the finishing off the vaccinations was what I call taking vaccines and turning them into vaccinations. So it was things like the logistics and training involved in making all that happen. So I should stress that I'm not a medical person. I'm a social scientist. I've worked as a work health and safety inspector and advisor. And I see, just to finish off, vaccine hesitancy is a continuum. It's a multifaceted challenge for public health. And of course, we're now seeing some of those challenges with measles reappearing in the US and UK, diphtheria in Australia, and possibly COVID fatigue. But that could be one of the things we'll discuss in the multifaceted space. So I'll hand over to one of the others.
Thanks very much, Chris. Julie, if I could bring you in.
Yeah, hello everybody. Good morning, good evening. My name's Julie Leask. I'm Professor of Public Health. I'm based at the University of Sydney, which is where I got this Zoom background from. And we have some beautiful buildings there that try to emulate Oxbridge. I'm a social scientist. I specialise in vaccination, and I've been doing this research since 1997, so for a fair while now. I have a small research group at the University of Sydney. We're called SABI, Social and Behavioural Insights in Immunisation. And we look at all the aspects, the social, the policy aspects of vaccination. Previous to my role at the University of Sydney, I worked at the National Centre for Immunisation Research and Surveillance in Sydney as well. And I was there for 12 years. But my original experience is as a nurse and a midwife, followed by a master's in public health. So I have some clinical experience from long ago, and most of my work now with the team that I work with focuses on the what people think, feel, and do about vaccination. And also doing work with governments and UN agencies like WHO in advising them on the best ways to manage communication back about vaccination from an individual and a community and through to a public perspective. Thank you. You're on mute, Guy.
Sorry, got noise in the background. My apologies. Neil, over to you.
Thanks very much, Guy. I come from a different perspective. I'm a vet. but I did 30 years in the army, and quite a lot of that time I was involved in the management and uh, development of vaccines, particularly things like anthrax and plague vaccine. So I'm coming more from a One Health perspective. I also was literally up to my eyeballs during the foot and mouth disease outbreak here in the UK in 2001, from the tactical right up to the strategic. And during 2015, I was the commander medical for the UK's response to Ebola out in Sierra Leone, and worked very, very closely with um, Sierra Leone government and various NGOs dealing with the managing the outbreak. So I come very much from a One Health perspective, and there's a few sort of experiences that I've got that we may touch on during the discussion. But I know my wife and I also own an exotics only practice here in the UK. So we're dealing with the animal vaccination questions and the vaccine hesitancy that comes along with that population as well. Thanks.
Brilliant. Thanks very much, Neil. I thought I'd just start the discussion by going through some of the headlines in the UK that have occurred recently with regards to measles, and the fact that there have been 2 deaths this year of young children so far from measles, compared to the previous 4 years where there were 3 deaths in total. This has sort of indicated that the vaccination rate has gone down, and that the rate of disease is going up. So that equates to, I think it's 959 cases in 2005. But so far this year in the UK, we're just about halfway through, it's 736. So it would appear that there is a certain amount of vaccine hesitancy out there, certainly in the UK, and I think that's reflected in the US as well. Chris, if I could ask you to come in first and just give the views of Australia and what's happening there with regards to vaccinations and whether there is a fallback from them.
Well, that's a small question there, Guy. There does seem to be some diminishing of numbers when you're looking at the raw numbers of vaccinations, and just exactly what's driving that. Well, Julie and some of her colleagues might well be able to lock some of that down with some more research. But I've also worked with Aboriginal people, and of course, one of the things that I think is sometimes underestimated in this space is the actual difficulty in getting vaccinations. So even if you're not hesitant, but you would like to have the vaccinations, sometimes it's extremely difficult. For instance, my stepdaughter's recently been working in an Aboriginal community, whereas over 400-kilometre drive, and we've had difficulties with fuel lately. So there can be financial and logistic problems, as well as perhaps misinformation, disinformation, and a lot of other factors coming into that mix at present. But I think it's perhaps a little early to be really solid in our understanding of why we're seeing these declines. And I'm sure Julie and other people will inform us when they've had more time to gather the necessary data and try and lock down why we're seeing those declines.
Yeah, thank you very much, Chris. Over to you, Julie. Is there hesitancy going on? Is that increasing?
Yes, a little bit. We do an annual survey called the National Vaccination Insights Project with our colleagues in other institutions. And we survey 2,000 parents of children about their childhood vaccines. And we survey 2,000 adults in relation to adult flu vaccines. Now, in the survey of the parents of children, we've got data from 2024 and 2025. And we did see a slight increase in the proportion of people who did not trust information about vaccines from their doctor or nurse, from 6.5 to 9.2%. So it's not much, but it does indicate a concerning trend in a slight increase in mistrust. And there's also more concern about vaccine safety. However, this really adds to what Chris was saying, that access to primary care is also a big issue. So while this webinar is on hesitancy, which is deeply concerning and challenging insofar as it can lead to non-vaccination, access to primary care has also dwindled, and also financial distress has increased in Australian parents. And whenever you get people whose everyday lives are more challenging, who can't take time off work easily, who are struggling to get to appointments or pay for a GP appointment, you're going to see a decline in vaccination rates as well. So broadly speaking, there's the changes in access and some slight changes in acceptance as well. And my awareness of what's happening in the UK is that you've got a similar thing, but of course with measles, you've got cohorts of people who haven't had their childhood measles vaccine because you had a big vaccine safety scare back in that started in 1998 that has affected whether young adults are up to date with their measles vaccines as well.
And do you think that scare in the end of the 90s, it was to do with vaccinations being connected with autism in the UK, and that was then completely disproved? But do you feel that it was communicated strongly enough to sort of try and build confidence in people?
In a way, ironically, I'd say that maybe it was too strongly communicated because the government at the time were, they were fighting an uphill battle because you had the press, you had the charismatic Andrew Wakefield who advanced this theory that the combined MMR vaccine might cause autism. You had parents of kids with autism who believed the link and were there to be interviewed in the media. So you really had this scare in the UK catch fire, particularly because of the interest in the media. And so I think it was very, very challenging for the government. But what they did was that they did a Get the Facts campaign. And I think also they communicated this sort of, they were aghast at people not vaccinating. And what we've learned about vaccine safety scares is that you have to apply the principles of risk communication in showing empathy to people's concerns, in being very strategic about the way you manage them. And that's not an easy thing to do. So I think a lot was learned from that scare.
Yeah, thank you for that. And Neil, I know that during your career, uh, pardon me, I think I've just swallowed a fly. Uh, you've got quite extensive experience to do with the military in Iraq and vaccinations there, and the way that was communicated.
Yeah, it's interesting that this was also 1998. And at the time, there was a concern that Saddam Hussein was going to reinvade Kuwait. But also in the context was there was still a lot of discussion about whether or not there was a thing called Gulf Veterans Illness or Gulf Veterans Syndrome that may or may not have been linked to pharmaceutical products that were used during the 1991 operation. And so a decision was made, for sound reasons at the time, to offer anthrax vaccine to troops who were going to be in the area. So not only soldiers, but also Air Force and Navy. But instead of just communicating it as, right, this, we think you need this, they actually had a letter from the Secretary of State for Defense that went to each individual person who's going to be offered the vaccine and their next of kin. And it comes back to what Julie was saying about risk communication, and you can over communicate that. Soldiers have had lots of vaccines by the time they get out there. You routinely use yellow fever, as well as the more, like we say, more traditional vaccines. And so suddenly to have a letter saying we really want you to have this vaccine made people, I think, wary. Why are you doing this? Are you trying to take responsibility away if there are any negative effects of this product? And that actually had a big impact on the on the take up of the vaccine, because the UK has always had a voluntary vaccination policy, apart from a short period of time under the early part of the 20th century when there was mandatory vaccination against smallpox. It's not within our culture to have mandatory vaccines, and therefore having been pushed to do this actually caused a lot of concerns. And I think it's a really good example about the communication has got to be correct. It's got to be from the right channels. Um, and it's best coming from respected medical personnel rather than I mean, it can be backed up by political or other leaders, but there must come with some directly from medical personnel.
Thanks very much for that. It's that's good. And Julie, I'm interested as well from the sort of points of view of vaccinations, with regards to corporate risk registers and things like that that companies and organisations will have. Is the lack of vaccine availability or hesitancy, is that something that should appear on their risk registers?
Um, could you elaborate on that question? Because I'm not a risk management person, so
Okay.
I'm not familiar with them.
Sure, sure, no problem. I mean, many organizations, companies, and things like that will have a risk register where they'll score various risks that are very high, such as an act of terrorism or a flooding or something like that. And it's whether that vaccine hesitancy could actually be something that should be considered should they have a virus go through their building, which could have been vaccinated against. There was a company I previously worked for during COVID, paid for our vaccinations, and they were very cognizant that they didn't want anybody going off sick. And we had someone from the health sector in the UK yesterday who made a contribution, sort of saying then it wasn't compulsory within the health sector, but it was sort of virtually as insisted upon. Is that something that should be considered in organisations' policies?
Yeah, possibly. Although again, I think the first thing organisations need to think about is how to engage their workers well with vaccination. And we saw this during the pandemic, that organisations were one of the most trusted institutions for people, their own employer, and they would look to them for information. But what you often see nowadays is in peacetime, so to speak, vaccination is not necessarily well promoted by organisations. So I think that's sort of that ongoing, routinized communication about, for example, in the flu season, your flu vaccine, you can get it easily from this service. It's very easy to register. There's plenty of appointments available. That would be one of the most important ways of managing risk in engaging employees. And in terms of vaccine hesitancy, I would say that's not the pathology. Vaccine refusal is the behavior that can be a problem, but also people inadvertently not being vaccinated because they're not aware they're recommended it and so forth. So probably thinking aloud here, vaccine hesitancy, should it be on a risk register? I don't think so. I think what could be on a risk register is the institution's actions in ensuring makes it engages with its employees, informs them, makes that routine vaccines easy to get if they're providing them, and also is very clear on its definitions. And vaccine refusal can be a problem if it's at scale, but there are bigger problems for organisations, I'd have to say, around vaccination.
Yeah, because I'd imagine they would have things like pandemics on the risk register anyway, sort of thing, so you never know whether that pandemic is going to have a vaccine available straight away or not. But
That's right, yes. And it would take some time, usually would take some time for the vaccine to become available and then to be rolled out. And you want to make sure that before you do make any strong policy actions to get people to vaccinate, that they've had a good chance to access the vaccine, they've been communicated with well, they understand why they're being recommended the vaccine, they understand about its safety and so forth.
Yeah, thank you very much. Ewan, you've just posted an interesting question. Would you like to come in and ask Neil?
Hello, can you hear me?
I can, yes. Welcome, Ewan. Nice to hear
Yeah,
from you.
yes, indeed. A great opportunity to get up early and enjoy a good long walk in nice sun before the sun gets too dangerous. Thank you, everyone, and thank you, everyone in Australia, for giving up their evening. Yes, it's a rather open question, and I'll leave it all to yourselves to interpret it. But Neil, you've obviously worked directly on the Big E. You've worked in West Africa. To what extent did the countries there deal with the aftermath of the last outbreak of Ebola, and equally vaccine hesitancy? And do we know if those lessons, the dreaded term lessons learned, have been taken on for recognition by national governments, medics, private sector, and indeed the pharmaceutical companies regarding getting the message about the vaccines out? Because one thing does strike me, it does look as if we're in a new era of hopefully better vaccines, but certainly faster vaccines. And much of the benefit of that could be lost if people don't have faith
Yeah,
in the system. So over to you, Neil.
there's some very good
Over to everyone,
everybody. So
actually.
I'll go first if that's okay. But you made some very good points there. I mean, when I was in Sierra Leone in 2015, there wasn't an issue of vaccine hesitancy. There was vaccine desperation. Um, People wanted vaccines, and they were being developed. They did take time, and obviously you can't you do have to be careful. And the issue we had was we did, towards the end of the outbreak, have a vaccine that was available, and the intention was to use it as a barrier, as a ring fencing for outbreaks. But there were logistical issues with it, in that it had to be kept at -70 and then used with a very short period of time once it had thawed out, which would be challenging in any scenario. It's certainly challenging in upcountry Sierra Leone. My understanding with the current one is that the current outbreak is that this is a different strain, and I don't know how strain specific the vaccines that have been developed, because normally most of the outbreaks have been Ebola Zaire. This one isn't. It's I can't remember the strain name now, but it's a different strain, and I don't know what the crossover is. But I would say, and it's something we may get to discuss further, I think in the face of an outbreak, in the face of being in the scenario where people are being severely ill or dying, people's attitudes to vaccines are often very different. So the polio vaccine, when the polio vaccine came out, people knew people who died, maybe friends, relatives, colleagues who died or been severely impacted by polio. I remember as a boy having a teacher at school who was didn't have the use of one of his arms because he'd been affected by polio. Now, when polio is incredibly rare, obviously there's like, do I really need to have this? As I said, back in 2014, 15, people were desperate for a vaccine, and a vaccine is a tool in managing something like an Ebola outbreak. You're talking about something that is infectious, but it's not infectious by aerosol. It's infectious by direct contact and contact with bodily fluids. And some of the way of controlling the disease is about changing people's behaviors, and particularly around around deaths and death rights and so on, which is really difficult to do because these are culturally really embedded in societies. I don't know, anybody, Julie, Chris, do you want to come in on this?
Neil, I certainly, my observation from afar, not having had the experience you've had, is that the community engagement was very important for getting community trust sufficient that you could change the burial practices. And at one point, a whole lot of anthropologists were hired to go and work with communities. But unfortunately, with the pullout of US funding, some of that work, as I understand it, has been neglected. And of course, the current outbreak is in a conflict zone where that kind of routine work would be very difficult anyway. So that has led to a reversion to burial practices and sometimes very strong resistance to Ebola workers trying to safely bury bodies and even violence. So it's a very difficult situation, partly thanks to the pullout of funding from the US government in quite a lot of work that had been going on in African nations.
Yeah, thanks, Julie. And I certainly I was doing some work in West Africa at the same time in 2015, but it was in Senegal. We took the police leaders from the three main affected countries and held a week's seminar effectively in Senegal. And they found that it was extremely difficult, even within their own staff to change any cultures with regards to deaths and the washing of bodies and the fact of burials. And they said it became even more complicated with people putting corpses in vehicles and driving them out into the countryside to bury them. And then if they were involved in a vehicle accident, the police and emergency services had turned up, didn't actually realise that they were dealing with a victim of Ebola as well as the other victims of the crash, which would mean the spread would go very quickly into the emergency services as well. So I think culture is a major problem. But Chris, did you ever do much work on Ebola previously?
No, not on Ebola, but I was just thinking about a major exercise that I was involved in Africa on a border post between South Africa and another country, and looking at the close contacts and thinking in this particular scenario, the scenario was cholera, but it could have been any number of other things. And for instance, the border post was right beside a beauty shop and a hairdresser, and there were people right up against the fence where the pretend victim was writhing about on the ground, and just thinking how difficult it would be with contact tracing if you find yourself with any kind of infectious disease, and the sort of nature of connection that you see, perhaps even more so in some African locations than you might in more European contexts.
Yeah, thank you for that. Neil, I just wanted to bring in also the animal concept, or not concept, but the issues with animals, because obviously they don't really have a choice, and it's more down to farming policies and things like that. But how do vaccinations work within the livestock arena, and how sort of are they made compulsory by a government, or is it a farmer's choice?
So most vaccinations involved in is about protecting young animals from diseases or conditions such as blue tongue. And actually, they're an economic, generally speaking, they're an economic decision that farmers decide whether the cost benefits are there. But the cost benefits could be more than just the actual uh, individual animals. It can actually be down to the status of the flock or the herd. So if you are protected against particular, if you can eradicate certain conditions out of your your flock or herd, then that actually gives the ability for you to trade those animals. It maybe increases the value and is good for business. So all these things need to be taken into consideration. But during the Port Maltese outbreak in 2001 was really interesting because that outbreak was an unprecedented outbreak in the UK, and again I was involved, right at the front line and also up at the in central government with it. And the debate was how do you control it, because this outbreak cost the UK somewhere between £3 and £9 billion. It caused elections to be delayed. There were these inflammatory headlines like the countryside on fire, and such things. And it is a nasty disease, but also it's really important from a international trade point of view. So the UK had never had a vaccination policy, and there's some reasons for that. Some is the vaccines are age strain specific. They don't have a long degree of duration, and if you vaccinate an animal that's incubating the disease, you will actually get an asymptomatic shedder. So an animal that's shedding virus that has no or can get that and has no symptoms. And those are all the reasons why we've not used vaccination in the past. But back in 2001, they were very keen to get things back to normal. And actually, there was a vaccination plan drawn up, and actual antigens were purchased and able to vaccinate. But one of the decisions for not vaccinating was actually reluctance from the supermarkets to actually accept meat from animals that had foot and mouth disease vaccine. They felt that the public might turn against it, and there were other factors as well, but certainly that was one of the factors involved in the decision that to not bring in the vaccination policy. And also robust movement control, veterinary epidemiology, and so forth. Did bring it under control. But it was considered, but there was definitely a hesitancy over actually doing it.
Thanks, Neil. That's very good. The session is called Ask the Expert. I'd like to invite anybody to put their hand up and come in and ask the team anything they would like. There is no such thing as a silly question. If not, Robert, too good. Could I just ask you for your opinions on this and your experiences?
Yeah, certainly. I'm interested in this topic from the point of view of civil protection. Getting involved with some activities in the UK next month actually, the University of Bath, where they're attempting to resurrect, I suppose, some of the protection or the protectionary measures that used to be in place sort of during the Cold War period. And I'll be fascinated to see how they brief participants in this 2-day experience, which includes kind of extensive exercise on some of the risks that we now face that possibly we weren't facing in the same way back in the 70s and 80s. I think from my own experience, because I remember doing an assignment with Johnson & Johnson during the first pandemic sort of threat or risk period, where obviously a lot of preparation was put in place, but it wasn't actually, fortunately, it wasn't needed. And of course, I've experienced the second pandemic that affected the whole world just a few years ago. So I'm looking at it from a holistic point of view to see how organizations have learned from what's happened in the past, so we can put in place those lessons for the future. But like with all these things, it's about how you re-educate board members to look at these sorts of risks in a different way, because the pandemic risk is there, but does it appear on many organizations' risks, strategic risk registers? Maybe, probably in most cases not. So I think it's about joining up the dots and making sure that the senior decision makers, particularly board members, really understand the world in which they're operating. And as I said, and others have said on this call, we learn from the past. because it's ridiculous that we keep making the same old mistakes, or we choose to ignore the things that we should have learned, decades ago. But that's the world in which we operate.
Do you think that that good old phrase of learning the lessons,
Mm.
is the fact that people read about them, but they then don't do anything about them?
Well, exactly. Well, there's a combination of things that we're familiar with swans, but some of us might be familiar with the old grey rhino. Why do we choose to ignore these things in the boardroom? But it's also, I think, connected with the way we think as individuals, and of course, the way we think is under threat at the moment, as with the ever increasing use of AI, because people are losing the ability to think independently. They don't think critically. They don't think in a way that challenges what they're actually taking on board in terms of information. They just take it as being, well, this must be the truth because it's in front of me. So we live in very dangerous times because we are at risk of becoming simply slaves to technology, and which clearly isn't a very clever place to be.
Yeah, yeah, not a great decision
Can I
maker.
just jump in there, Guy? Actually, I mean,
Yeah,
I
please
forgot to
do.
comment on Ewan's mentioned lessons learned as well, and I have a similar cynicism about these lessons learned, and I always think we should call them issues identified because they're issues and not lessons, and we never learn from them.
Yeah, or
And
lessons to be learned or something.
yes, and but there is always useful looking back into historically what happened, but it's a question of being able to translate that into what the current what the current scenario is. And the thing is about particularly if you're talking about sort of civil protection, civil defense here. The issue is that not all diseases act in the same way, not all vaccines act
Mhm.
in the same way, and it's really having the understanding what it is you're going to be faced with, and therefore what's the best way of responding. I mean, it's now quite old now, but there was a thing called the Foresight something or other that was produced about 20 odd years ago, which was looking at potential new infectious diseases in the UK, and that came up with a figure, and actually I've seen used quite a lot since then. Is that about 70% of emerging diseases are zoonoses. They actually come from animals. There is this spillover
Mhm.
and an adaptation. And there's I know there's a debate on about where did COVID 19 come from? How did it get there? But we see this with recombinations with influenza vaccines. I mean, COVID is a coronavirus. There are loads of coronaviruses
Oh,
out there, and
yeah.
it's very difficult to predict what's going to be next. There's Ebola is actually is a the reservoir is a fruit bat.
Yeah.
Um, it's only when you have an intimate interaction with the fruit bat, like eating it, that you actually get the infection. So it's really about, from a planning point of view, you've got to understand the disease, but also you have to understand the hesitancy piece. What's going to make people reluctant to take on a vaccine, and it comes back to this issue of risk communication again.
That's right, and I think also with when we look at things like vaccines, and viruses, viruses are constantly, the little I know about them, they're constantly changing, they're constantly mutating, they're constantly, presenting new challenges. And I remember going back, quite a long time to that first pandemic scare. Some of the resources that we were given access to were incredible. So it's just like the sort of cyber moving graphic type resource you go to now, where you can see all the different attacks. It was the same sort of thing going with viruses, And I think one of the nightmare scenarios, again from the little I know about it, was in some darkened alley in the back of, I don't know, some far-flung country, virus A meets virus B, and they have a love child, which is just incredible. So it comes back to, I suppose, also the need for organizations to be resilient, because in the same way with a cyber attack, you think you might have cracked it. In reality, you haven't, because they've come up with another way of getting in. Yeah. And we've got the same thing with this sort of area of pandemics and viruses. That organizations need to be more resilient, or be resilient in different ways, which allow them to respond to these challenges as and when they arrive. It comes back to the way we going if we think about risk registers. Well, where do we position this? Because it is interesting when you look at pandemic planning, it's fundamentally different to continuity planning. Because with continuity plan, you might want to move everybody to the same location. We definitely don't want to do that with a pandemic. So there's some subtle differences. Yeah, at the end of the day, it's about, risk management and, well, is this a risk we're willing to tolerate or not? And in a lot of cases, I think they're organizations are, digging their heads and, just burying their heads in the sand and thinking it's not going to happen because they've got bigger things to deal with today, which are issues. So I always remember trying to talk to a senior decision maker about risk management and a particular initiative we had. And I came away from that discussion thinking, well, hang on a minute, this is like talking to somebody about redecorating the living room when the whole house is on fire, because they're dealing with issues. They're not, risks of things that might happen. And you could argue, well, this hasn't happened yet, but well, I think it has happened. And you can apply the same logic to other situations like climate change. Climate change isn't a risk; it's an issue because it's already happening. But it's about communication. Yeah.
No, thank you both very much for that. Maria, I'm interested to hear what vaccine hesitancy is like in Serbia and Hungary, that sort of region. Is there a lot of skepticism, and are they widely available?
Well, yeah, it's kind of a mixed message. So, vaccine hesitancy in both Serbia and Hungary. So, it sits mainly in the space where public health meets trust in institutions, and it becomes more visible when you look at concrete moments rather than some general attitudes. So, for example, in Serbia, the early COVID-19 rollout is often mentioned. So, vaccines were quickly available and there was a very wide choice. So, we had Pfizer, AstraZeneca, Sputnik V, Sinopharm. But the messaging about which vaccine was preferable shifted over time. So that actually combined with visible disagreements among experts and public figures, and it all created a sense of uncertainty rather than clarity. So people often defaulted to personal judgment or community experience instead of official advice. And the same trust dynamic carries into childhood vaccination. So, parental hesitancy, especially around MMR, so it is shaped by several practical, some real world examples. So, one is the persistence of older safety concerns that circulate through social media and word of mouth, even when they have been officially disproven. So another one is a strong reliance on pediatricians or family doctors. So when communication is inconsistent or some appointments are delayed, parents are more likely to postpone vaccination. And the third one is like the low perceived risk effect. So many parents have never seen diseases like measles. So the perceived urgency is lower than concerns about side effects. And over time, these factors can lead to delays or uneven coverage across regions. And in Hungary, so the early inclusion of non-EU vaccines like Sputnik V and Sinopharm helped speed up rollout, and initially it supported the uptake. But later, EU-level debates about vaccine procurement and mixed media narratives created more selective skepticism, especially in some urban, highly informed groups who are exposed to competing informal information sources. And so in both countries, in both Serbia and Hungary, childhood vaccination is required for daycare entry with parents expected to provide records. So if they don't, the process is administrative. First, there are reminders or follow-ups, and followed in persistent cases by formal procedures or fines, depending on the enforcement. And in Serbia, when parents hesitate about childhood vaccination, especially MMR, it's usually expressed in a very everyday practical language rather than some ideological position. So typical things parents say is like, not yet, the child is too small. I'll wait a bit for the child to get stronger. The doctor said we can postpone it, or I heard someone's child had a reaction. So often the underlying tone is caution rather than rejection. And what stands out is that hesitation is usually framed as a delay. So wanting more certainty, waiting for the right moment, or relying on personal stories rather than a clear refusal. I know about this firsthand because I'm a parent, so I have a 3-year-old and she is fully vaccinated for her age. So in both countries, hesitancy is less about rejecting vaccines outright and more about how stable, consistent, and credible the information environment feels. Thank you.
No, thanks very much, Maria. And Julie, does that resonate with a lot of the research that you've conducted?
Yeah, absolutely. In fact, I went to Serbia a few years ago with the European Office of WHO to work with the Ministry of Health there because they were very concerned about MMR vaccine uptake. And a lot of this does resonate. What I think also where they landed with this workshop we did was that they decided they really needed to skill up pediatricians in having good vaccine conversations, and that there was this sort of model of paternalism that wasn't working for the new generations of parents who wanted to have informed choice and information and not just feel like they were railroaded into vaccinating. And they also needed to improve the education of pediatricians because, of course, vaccination, is an ongoing learning process, and there's no end to the sorts of questions that you can get as a clinician about vaccination. So I think they ran education seminars with pediatricians, and they developed some materials that improved the consent process as well. So they were the two sort of strategic ways of trying to deal with this problem of MMR rejection in particular, because that UK controversy that started in 1998 with the now retracted Lancet article has had worldwide effects and continues to have them, particularly through the US government now.
No, thank you, Julie. And Chris, any views?
Yes, it's back to this multifaceted point that I made earlier on my remarks, where there are so many things feeding in, and whether it's vaccine hesitancy, availability, consistency, quality of information, defending against misinformation, providing information from trusted sources. There's so many variables here. I mean, the list is long, and all of these things that have to be attended to in order to build the confidence for people to come forward and be vaccinated against diseases that we know where high levels of vaccination are extremely helpful, such as measles is a great example of that. If you get the herd immunity up, then the likelihood of the smaller number of people who are unvaccinated being kept safe. So there's a whole lot of variables. So Julie and her team and others will have plenty of research questions to consider as they work through some of these possibilities of explanation.
No, yeah, thank you. Julie, you have your hand up.
Yeah, if I could just weigh in, because Chris, you're right. It does seem very terribly complex because it's got all these layers to it, vaccine hesitancy and refusal. I've found a very helpful model, if you like, is the UNICEF Journey to Vaccination model, which is you imagine a figure of eight, and on the left is the preparation and getting ready to go and have a vaccination. And on the right is the point of service and experience of care. And thinking through it in that journeys model can be very helpful in terms of thinking of the touch points at which you might need to address hesitancy, because it is so contextual. It does require you to be aware of people's experiences, historical injustices, particularly for Indigenous communities, that affect their approach and their beliefs, and also people need to be merely aware that a vaccine is due. And then when people are getting ready to vaccinate, social influence is incredibly powerful. And that's why we do a lot of work with communities and training vaccine champions. And then when you're thinking about preparing to go to that vaccination appointment, or where the service comes to you, as it does in many countries, you're thinking about the logistics of cost, of getting childcare, of remembering, of navigating gender issues such as a lack of autonomy for women to decide and travel to vaccination. And then at the point of service, that's where the healthcare provider really comes in and their own context. And, do they have the time to address questions and concerns? Do they have the knowledge? Is the experience of the service a good one for the parent or the other caregiver? And then the vaccination encounter itself and what that's like. Is that done well? Is communication managed well? Are there concerns and questions managed well? And then after the service, which is that final point in the journeys model, which is where particularly you're wanting to address any concerns about reactions or get people ready for any common side effects or what to do if there might be a serious rare side effect. And we found in our research that a traumatic experience with vaccination is a particular driver of future refusal or hesitancy. And managing those experiences, whether they be about vaccination or more broadly about healthcare, labour and birth, for example, those experiences can have such a foundational impact that we think it's worth putting a lot of time and effort and investment into managing adverse events following immunisation really well.
And do you think the method of delivery is one of the sort of potential barriers in that it's mostly an injection?
Yes. People don't like needles. I mean, none of us on this call would say we particularly enjoy getting a needle for our annual flu vaccine, for example. Um, but the exciting thing is that there are new technologies that might avert the need for a needle, such as with microarray patches, which are small patches which scratch the surface of the skin and put the active component of the vaccine, the antigen, just subdermally, and that they're in phase 2 trials now, and there's a real interest in these because they'd simplify delivery, they'd address cold chain issues, and they'd also make it much less distressing for parents and children and adults receiving vaccines as well.
Thank you. And Ewan's put an interesting question of whether there's commonly occurring and significant differences and uptakes between different vaccines for different diseases.
Yeah. Yes, there are. So it's usually milestone specific. So children are let's, are more likely to be vaccinated for the very early vaccines. There is there's a hepatitis B vaccine offered at birth, and there is a little bit more refusal of that at the moment, I think, in some countries because of the whole RFK Jr. effect, where he's criticizing that vaccine, as did Trump in a press conference last September. And then the routine vaccines given to children, such as diphtheria, tetanus, pertussis, polio, Hib, hepatitis B, throughout that first year, coverage is usually reasonable. And then it does tend to drop off, say, for the 1-year-old vaccines, both for practical reasons, but also with MMR vaccine usually due at 1. Some people can, still a small proportion depending on the country, but some people can preferentially reject that vaccine because of what they might have heard about an alleged link to autism. And then as you go on, booster vaccines at later age groups the coverage for those can be quite low depending on the group and reminders that people get. And finally, with adults, in Australia, for example, only 27% of our over 65s have had all the recommended vaccines for them. For influenza, vaccination coverage ranges from 62% for the over 65s to down to 25% for young children, yet it's recommended for them. So it can be highly variable. You're right. It's a great question, Ewan.
Thanks very much, Julie. And we're getting towards the end of time now. I just wanted to ask if anybody had any questions for the panel. If you could just come in or raise your hand, that would be really good. Andrew Blades, good morning, and thank you for attending both sessions.
That's all right. I like to be an overachiever guy. So I've got a question, and it comes back to the Lancet article. So for all three panel members. So the the Lancet article was retracted. The article on thalidomide was retracted. I think last year there were roughly 10,000 scientific papers retracted. So my question here is, are we seriously wondering why people question science when so much of what we're told is accurate is later retracted? Now, I'm as I said in the previous session, Neil was there. I'm vaccinated. I think my doctor just likes jabbing me. I get that many of the damn things. But I look at a lot of this and they say, well, trust the science. Not sure that if you're a scientist or from a science background, you can say trust the science when so frequently there is dodgy science. So just a thought on that. I'd like to sort of, how do you think that it sort of informs people's attitude to authoritative science-based discussions?
No, thank you, Andrew. Julie, I'll go to you first.
Yeah, it's a great question, Andrew. It's a really good question because I mean, none of us can say that science is one immutable thing. It's a process and it is flawed. And depending on your epistemology, is it ever possible to behold one single absolute truth? We cannot say that vaccines do not cause autism because it's impossible to prove a negative. So we can only say that we have great confidence that vaccines don't cause autism based on the best available evidence we have so far. And that's often why I so qualify what I say. I'm trained in epidemiology, and I know because of that there's good and bad studies. There's poor quality and high quality, and then there's the need to repeat your findings to be very confident in them. In terms of trust in science, there was a study published in Nature last year, which is a good journal and doesn't publish junk like many journals do nowadays. And it found that trust in science had not declined that much, depending on what country you were in. But certainly in Australia, it hasn't declined that much. So, it is an issue with some groups for sure. And we know that when we talk to people and who feel like they have less trust since the pandemic. But I think the way we talk about science in science needs to be a lot more humble. And the keyboard warriors who bang the keyboard and say you need to trust the science on vaccination and just vaccinate do not have enough nuance in these discussions to be able to give people the information they need, to be able to talk about risk so that people can know its boundaries and stare down that and know that the benefits outweigh those risks. So, yeah, the arrogance in the way we sometimes talk about science can be problematic for hesitancy.
Thank you very much, Julie. Neil, I could see you nodding your head there.
Yeah, absolutely. I mean, I think the thing to remember is that things like the papers in journals, they are peer reviewed. So somebody has written something, it's then sent out to 2 or 3 other people who the authors don't know who they are, who look at it and comment. They can make suggestions as to changes, but they're also trying to be, these papers are saying, right, this is new, I found this out, this is what my evidence is. And the reviewers are looking at it and say, well, does this stack up? Is the evidence strong enough? Have they, was the study robust enough, and so forth? But they are individual studies. They're not the same as, for example, something that's gone through a rigid regulatory process, and even then, there is an evolution in regulation. Things happen, and new things came in. I mean, thalidomide is an interesting example where actually things were ignored. It wasn't that should never have got to the place where it was, and but there is this pressure on people to publish and to get things out there. And so I think you always got to look at, look at peer-reviewed articles with an element of analysis and criticism. Certainly, there is across the piece, not just in vaccines. There is an issue in biomedical research, particularly with animal use, is about reproducibility. And how much is it the environment, how things will differ from lab to lab, and so forth, and what other factors are you trying to control factors, but how much does the biome, for example, have an impact on results for different studies. So I think we need to peer-reviewed articles are good, but they it's not surprising. At the figure of 10,000 a year withdrawn, whatever it is, there's probably millions that are published, and I think all of us have probably looked at an article and think, well, I don't agree with that. I don't agree with the methodology. And basically, it's the best we've got to produce new scientific evidence in a timely manner. And it's but these things are open up to scrutiny. Just the other point I would make is this issue about needle aversion, and I was thinking about this last night actually. Needle aversion and injecting things into bodies, it's like people are reluctant to it. Yet we're seeing this huge popularity of the GLP-1 blockers. The people are out there for clinical or cosmetic reasons wanting these things. There's a black market in them. So it depends on the scenario that people, in some cases, are very keen to stick needles in themselves. And it's really interesting how we have this cultural reluctance and fear of vaccine leading to vaccine hesitancy, where for other things we don't. And I'm sure Julie's done a huge amount of work on those sorts of things, and I think it's a really interesting area.
Those GLP-1 needles are tiny, but the vaccine needles are a bit bigger. But actually, that needle distress doesn't seem to put a lot of parents off actually vaccinating their kids. It's more the worry about what's in the vaccine and its safety.
Yeah.
Thank you very much, Neil. And Chris, I'll leave the last word for you.
Well, just to finish on a somewhat lighter note, I mentioned that hepatitis B vaccination program that I ran for the police in Queensland towards the end of the 1980s. And we actually made a video to try and encourage people, to inform them and encourage them to go ahead with it, because it was all a bit mystifying to many people. They hadn't heard about hepatitis B, especially the vaccination. So I made a short video. And one of the stars of the video was one of my police colleagues, who turned out to be needle phobic and did a very good job of sort of looking very hesitant about getting a needle in the video. And people said, "Oh, did you give him a needle?" And I said, no, he's needle phobic. So it was an interesting actor that we got in that video. But the important point in all this is there's quite a lot of work being done in nasal vaccines, and I put a little note in that into the chat, because in some cultures a nasal vaccine will be better accepted. So I think this raises yet another point, that we need to be very culturally sensitive. And the work that I did with the World Bank included preparing low and middle income countries in Africa and Asia for the next pandemic under the HEPA program, Health Emergency Preparedness and Response. And yet I came back to Australia, and the last time we did a decent exercise in infectious diseases was 2008, other than, of course, COVID, which was the real thing. So sometimes we can be a bit hypocritical in the West. We're sort of telling other people to do these good things and even funding them, but not necessarily doing them ourselves. So how prepared are we for the next pandemic would be the thought I'll leave you with.
I think that's very true, and a bit of a scary question as well, because there's no doubt that we're not as well prepared as other countries like South Korea, who've had that experience and familiarity and retained the measures that they put in place, which I don't think certainly the UK hasn't done. Uh, it's past our time. So thank you all very much for joining today. Thank you, Chris, Julie, and Neil, especially for your contributions, and for everybody else who's taken part this morning. I'm going to wish you all a very nice rest of the day and an excellent weekend, and hope to see you all soon. Thank you and goodbye.